I am Katherine Woodfield, the author of Don't Buy That Health Insurance. One of the things I'd like to talk with you guys about is how our employers ended up with our health insurance. Now, most of us, if we own a house or if we rent, we're able to handle insurance for our own household goods, or we have homeowners insurance. And if we have a car, we know how to buy car insurance. When it comes to buying health insurance, very few of us have actually gone out and negotiated and figured out about buying health insurance. And there's a very specific reason for that. So how did our employers even end up with our health insurance? So I start the book by going a little bit through the history of how health insurance landed with our employers. It starts back in World War I. In World War I, after World War I, you may recall we had a big depression. And one of the constant themes you're going to find about health care is taxation becomes an ongoing issue, and the federal government has been involved in health care pricing as far backward as World War I. So what happens? During World War I, one of the things the government did in an effort to control prices is that they froze wages. So you guys are employers. So you've got a great employee, phenomenal. You don't want to lose this employee, but you can't give them a pay raise. So you go to the employee and say, look, I don't want you to go to another company where you can do the same job for more money because their wages were frozen at a different rate. I'm going to give you a benefit to staying here. And the benefit is, if you're ever admitted to hospital, I will make sure that your hospital bills are taken care of. So is it worth it for you to stay here if I take that risk off your plate? So that's actually the birth of how our employers come to even be involved in our benefit process and how it's called a benefit. It was a benefit to stay with that employer. So now we're going to fast forward. We have World War II. What happens after World War II? Huge advances in medicine. Penicillin, giant advances in medicine. And one of the things most people don't realize is that during this window of time, there were a couple attempts for the president would say, we need to have some sort of a national health care system because we've got all this great medicine now. We need to make sure all the people in the country have access to health care. So we fast forward, 1973. President Nixon, well, actually in the 60s, we have Medicare and Medicaid introduced. And I want you to know that right now I liken the time to what it must have been like 6 months before the launch of Medicaid and Medicare. We know something really big is happening. Laws have been passed. It's gotten through Congress. There's a giant change facing the country. None of us are entirely sure of what that change is, but there's a change coming in. That's where we are right now. And if you look at the federal budget, you can see the Medicaid and Medicare is a big chunk of our current federal budget. So now we get to 1973, and President Nixon passes some legislation called the HMO legislation. It has a longer name, but we'll just call it the HMO legislation. And what it was, a series of grants for not-for-profit companies to create health maintenance organizations, because we knew if we could maintain the population's health, we could head off hospitalizations. We've had big advances in science. We have a lot of new drugs. We have a way of keeping the population healthy. So these are all not-for-profit organizations. So what happens in 1973? You may recall, most people in here maybe don't remember, didn't have a car at the time, but there were really long lines. Really long lines. We had a giant financial crisis, and the federal government had just created a giant system of non-tax-paying companies. Well, that's no good. So they reversed the nonprofit and made them for-profit companies so that it was a tax basis. Okay, so now we fast forward again. By 1987, something like 80% of employers are offering health insurance benefits to their employees. Now remember, you're offering these benefits as a competitive advantage versus another company that may or may not be offering the same thing. But if everybody's offering the same thing, it's not a great benefit anymore. So one of the things that happened, and I read from the book, it's page 20, Clayton Christensen's book, The Innovator's Prescription, is a fabulous book. I learned a lot of information. To differentiate themselves in the markets for talent and for insurance, employers and healthcare plans in the 60s begin to promote comprehensive coverage, which include reimbursement for day-to-day health care costs. So here's the first fundamental principle we have to think about. Do you need health insurance to cover? Do you need insurance really to cover day-to-day medical costs? Remember, this is a marketing plan that's being put out by employers. So the best employers offer the comprehensive plan with the least amount of employee contribution to attract and retain the best employees. Before long, two types of employer-provided healthcare assistance, true insurance against catastrophic illness and reimbursement of day-to-day healthcare expenses, have been combined into a single package health plans. Now, one of the other things, if you look at healthcare prices as they're doubling and doubling, well, first of all, we just added all the day-to-day expenses, so that couldn't help but double a budget, right? I mean, you know, your disaster was big numbers, but now you added a whole bunch of little numbers. So that's how we started down the road towards having HMOs. And originally HMOs were good because it was health maintenance and it was something that really worked. Now the insurance companies are still for-profit, they need to differentiate themselves, so they start creating systems to differentiate themselves from other insurance companies. So the systems turn out to be networks. So one network compensates at level A, another network compensates for the exact same service at level B, or 2 times A. So if you have an HMO, let's say the doctor diagnoses you with a sinus infection, he might get paid $25 for that job. If you have a PPO, he used all the same skills, but he's going to get paid $50. So we start taking responsibility for compensating our physicians more generously through plan design, but we don't realize that's what we're doing. So when they say this plan has a better network, it's because it's more generous with its compensation to the providers. One of the things an educated consumer needs to do is look out for you. Remember what we started with? Fixed costs low. Your job isn't to negotiate the physician's contracts, nor is it your job to make sure he gets compensated the most he can possibly get compensated for the services. It's his job, his office manager job, it's his job to run his business. It's not your job to run his business. If your premiums are escalating out of control, you can take control of them by one of the things you can do is not worry so much about how much the doctors are being compensated and how many people are in the network. Be more concerned about managing your fixed costs.